Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. As you know from watching this program, we have different healthcare professionals and people on the show that talk about services and programs here at KRMC. I've got a new doctor I'm looking forward to introducing you to, so stay tuned. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Dr. Carol Lee Collins. Thanks for being on the show today, Dr. Lee Collins.
Thank you for having me.
And you're a gastroenterologist, did I say that right?
Yes.
That a tummy doctor? No.
Yeah, stomach,
Yeah.
liver, colon specialist.
Okay,
Yeah.
very good. Well, we're blessed to have you in Kingman because we had a hole there for a while with no doctors to take care of that. So thank you.
Oh, you're welcome.
For coming here. So let's talk a little bit first about you and how you became that stomach doctor, and then we'll talk more about what you're doing here. So you're originally from
Chicago.
Chicago, okay. Born and raised there?
Yes.
Very good. Is that where you did medical school?
Well, I actually did do medical school at the University of Illinois in
Okay.
Chicago.
Okay, very good.
But I didn't go to college there. So.
Okay.
Yeah.
So then, and you mentioned your kids grew up in Tucson, so how'd you get to Tucson from Chicago?
Well, after I finished medical school, I did my training in Los Angeles.
Okay.
Both internal medicine, which is what a gastroenterologist does first.
Right.
And then gastroenterology fellowship, which is an extra time period. For me, it was 2 years after my residency in internal medicine.
So that's 8 years of school and then 2 years on top of that?
Well, it's 4 years of college, and I went to
Right.
the University of Virginia for my undergraduate degree, 4 years of medical school
Right.
at the University of Illinois, and then 3 years of internal medicine residency.
Oh.
And when I did my fellowship, it was 2 years, and now it's 3 years for gastroenterology.
But so 13 years, that's
Yeah.
a lot of school.
Yeah, it is. Yeah.
But that's a lot to learn too, my goodness.
Yes.
And having a specialty like that, obviously people are going to feel good about the fact that you've got that knowledge behind you.
Sure.
That's
Yeah.
good. And so then you went from LA to Tucson?
No, I went
Oh.
from LA to Indiana, actually. I was there for
Okay.
10 years.
Okay.
And then I went to Tucson to start my own practice.
Oh, okay. Very
And I
good.
had a practice until 2010 in
Okay.
Tucson, and I closed it and did what we call locums, which is just
Yes.
kind of filling in for doctors.
Right.
And then I worked in actually Bismarck, North Dakota for
Oh my,
2 years.
I know
before
Bismarck,
coming here.
North Dakota. That's cold.
Yeah, it's pretty cold.
It's welcome back to the warmer climate, right?
Yeah. So we wanted to return to Arizona, and this is a good opportunity. So
Absolutely. And your husband, now you shared your kids are grown up. Your husband's here.
my
is
husband's
it?
here.
And what does he do?
Well, he ran my practice
Oh.
in Tucson, so he's retired.
Very good.
Yeah.
Okay. And then your kids one's in college, you mentioned.
Yes,
So your son's in college?
Right. He's actually a junior at Penn State,
Okay.
and my daughter just graduated from the University of Virginia in May with a math degree, and she works for Moody's investors in New York City.
Oh, wow. Very good.
Yeah.
Very good.
Yeah, so we're very proud.
I bet you are. That's
Yeah.
awesome. That's great.
Yeah.
And what's your son going to do? Where does
He's
he
an
know yet?
economics major.
Okay, so they're numbers folks.
Right. Yeah. He's also actually a cheerleader for Penn State too.
Oh, very good.
Yeah.
Very good. Double proud.
Yeah.
That's awesome.
Yeah, so.
You mentioned your son has been here to visit. He came this summer.
Yeah, he stayed the summer with us.
Very. And what? Like, when did you come? I don't remember when you started.
I was here at the end of May.
Okay, so
yeah.
it's been about 4 or 5 months now, and from what I understand, you pretty much hit the ground running. We kept you busy almost from your first day here.
Right. There's a lot of business here. So
Yes.
and I'm the only gastroenterologist right now
In
in
Kingman,
so.
right.
Well, that the hospital owns. So
Yeah, right.
That's hospital employed. So.
Yeah. So you're seeing patients here at the Medical Professional Center. Do you know your suite? Is it
221.
221? Okay. And what kind of thing? And you mentioned stomach and liver, but what kind of issues do you see normally?
Well, we see a variety of things. The GI tract extends from the mouth all the way to the anus, basically.
Basically.
And also involves the liver and the pancreas. So we certainly do a lot of what we call screening colonoscopies for health maintenance for people after they turn 50
Yes.
for colon cancer.
I have to admit, I have to tell you, when I turned 50, I had my first one, and I told my doctor, that was when I was still in San Diego, and I told him, I said, now I know why people don't want to turn 50. It has nothing to do with age. It's all the benchmarks you make us go through.
Right, yeah.
Then I had my second one at 60 here, and that was a much better experience. But
Well, you know, it's something that you only have to do every 10 years
Right.
if you have no family history and you have no problems with your first exam.
Right.
Unlike other screening tests that are more frequent.
Right,
so.
right. So that's true.
And-
Once every 10 years, that's not so
Right.
bad.
And colon cancer, you know, can be largely prevented, or certainly the outcomes can be better if you have it and it's found early.
Found
so.
early. Yeah, so that's the important reason why you need
Right.
to have it done.
Right. And we put people to sleep. The preps are better than they were in the past.
Absolutely.
We use a very low volume prep, which is about 32 ounces altogether.
Oh, that's not
16 the
bad.
night before and 16 the morning of the exam. So, yeah, it's not as bad as it used to be.
Right. Yeah. I
Um,
think my first one, like you said, that was like 12 years ago now, and felt like I was drinking the whole kitchen sink.
Right, right. Well, we use a really good prep. It's low volume, and
Good.
people tolerate it really well. So,
Good.
yeah. But we see problems with the esophagus, which can be from heartburn or trouble
Oh.
swallowing. We certainly see
So like
stomach
GERD and
issues.
that kind of
yeah,
thing can-
acid reflux,
Uh-huh.
and you know, people can have trouble swallowing from just having acid reflux.
So, curious, what causes acid reflux?
Well, there's a variety of things.
Okay.
It can be related to what people eat.
Your
It can
diet,
be, yeah, it can be related to other problems in the digestive tract if you don't empty your stomach normally, or things like that.
So like getting constipated and things like that?
Not so much constipated. There are conditions where people don't empty their stomach normally,
Oh.
and so things kind of back up.
Okay.
But a lot of it, when you talk to people, it's the kind of things they eat. It can be due to medications. There's some medications that give you a propensity to have acid coming back up into your esophagus. So.
And that can cause damage if it's not dealt with, right? I mean, can that acids?
Yeah, the acid can cause what we call esophagitis, or inflammation of the esophagus, and in extreme cases, it can become a precancerous condition.
Wow.
So if people have acid reflux or heartburn more than twice a week, they need to see their provider.
Okay.
Yeah.
Now, speaking of that, so if someone has those issues, do they need a referral to you from their primary, or can they just call?
Well,
an
for
appointment?
simple heartburn, they don't need to see a gastroenterologist so
Oh,
much.
okay.
They need to go to their provider, and
Okay.
their provider can put them on medication.
Okay.
If you have what we call alarm symptoms, such as difficulty swallowing,
Okay.
weight loss, that kind of thing, then you need to see somebody like me.
Okay. And then, again, do they need a referral for
Yeah,
that
we
then?
do we request a referral
From
so
their
that
primary care,
yeah,
okay.
from the primary care.
Okay.
Just so that we know that the visit is appropriate.
Sure.
And that we're giving the best care that we can to that patient.
Absolutely. Well, and from an insurance standpoint, too, usually it helps for their insurance companies.
Yeah, a lot of
to have that.
insurances do require it as
that.
well.
So it just makes sense to follow the steps to
Right, yeah.
get the right, so you don't
Right.
end up with a big bill.
For sure, yeah.
Absolutely.
Mhm.
So that was the acid reflux. But then maybe we start here and work our way down and
Right.
talk about the different issues that
Right.
you see.
So we see, in the stomach, we see people with abdominal pain, and sometimes they have an ulcer, or sometimes they have other things that may cause them to have abdominal pain. So, we do investigations for that.
Okay.
The small intestine, you can have ulcers in the small intestine. Another thing that we see in the small intestine, or why we evaluate the small intestine, is to diagnose a condition called celiac disease. And that's a sensitivity to gluten or wheat products.
I've heard of it.
Right.
I've heard of that.
And so we do testing for that, because sometimes that causes people to have abdominal pain. Other symptoms of celiac disease could be people just have iron deficiency anemia.
Really? And that's a symptom of celiac?
Yeah.
I never heard that before. So
Right.
so if someone's having those kind of pains, or is
If they have an iron deficiency anemia, which hasn't been diagnosed by other means, that's one of the things that if you see somebody like me, we're going to check for.
okay,
And we do biopsies of the small intestine to make that diagnosis.
Oh, and is that something usually through diet and medication they're able to?
Celiac
handle?
disease is totally treated with dietary changes.
Okay,
Yeah,
because it's the gluten, so that's the
Right.
wheat.
right.
And what else did you say? Gluten and what? Or is that?
No, just gluten.
Just gluten,
Yeah, and we
okay.
put you on a gluten-free diet. But
Okay.
gluten is in lots of things.
Oh, I know.
Yeah.
Yeah, I've had some friends who've just gone on a gluten-free diet, to try to lose weight kind of thing. And boy, it's amazing. It's an awful lot of stuff.
Well, we ask that people not do that before they come see us.
Okay.
If there's any suspicion, because it can skew the results.
Sure, sure.
Yeah.
So
And then
now-
we send them to a dietitian afterwards if they
Okay.
have that, because it's in so many things that,
They need help figuring out what they can
yeah, a
eat.
formal evaluation is always helpful.
Sure. And I think one of the things that happens a lot of times, people go, oh, I can't eat this, this, and this. Well,
Right.
instead maybe focus on what you can eat.
Right.
That because there are still foods out there that you can eat, and sometimes you have to spend a little more time maybe grocery shopping to read your labels.
Right. Well, but most places, and I'm not sure about Kingman, but a lot of places have gluten-free sections,
Yeah,
or
I've
they
seen
have
them in
gluten-free
the
stores
stores.
even
Yep.
that have everything from pasta to bread to pancakes, waffles, those kind of things.
So what do they make it from rice, or what do they make it?
The flour is rice flour or something
Okay.
else.
Okay.
Yeah.
So it's the wheat.
Yeah.
That's the flour. That's the culprit.
Right. That's the primary culprit. Yeah.
Okay. And is that just something? I mean, is someone born with that propensity, or is it?
But you have a genetic propensity for that. Yeah.
Okay. And then maybe it won't show up till you're older.
Right.
Sometimes.
Mhm.
But you
Yeah.
see children with it too.
Yeah. It was first diagnosed in children, actually.
Oh.
Yeah.
Okay. And that's gonna be even harder with the little ones, because to figure out exactly what's going on and.
Oh, sure. Yeah.
Wow.
But again, it's a pretty simple diagnosis, and it's hard to change your diet, but it's not like you have to take medication for the rest of your life.
Yeah,
So.
so making a diet change is certainly preferable
Right.
to having to get shots or pills all the time.
Right,
That's
exactly.
a big thing.
Yeah.
And so that's the upper intestine. Now, you mentioned you do it through a biopsy. That's how
Yes,
you.
that's how you make the
Now,
diagnosis.
is that oral that you go down then? Are they
We
asleep?
do it through an upper endoscopy.
Okay.
Which is a scope that goes through the mouth into the esophagus. We look
Okay.
at the stomach and the small intestine during that exam.
And they're asleep?
Yes,
when
we
they have
put-
it done
we give
too?
them sedation for that.
Good. I just always think I'd rather just be asleep. Wake me up when you're done.
Right, yeah. Most people are like that.
Yeah.
Mhm.
Okay.
Yeah.
So then what's next? What other kind of, then you get into the lower intestine?
Well, we have the small intestine,
Okay.
which is very, very long, and we have instruments to get to different parts of the small intestine. We don't have all those here, but if someone needs that, we can direct them to a place where they have scopes that
Okay.
are longer to
Okay.
see the entire small intestine. And then we
Wow.
have the colon, which the primary way of viewing the colon is a colonoscopy.
Okay. So when you do a colonoscopy, it's pretty much just the large colon that you're looking at?
Well, the colon is the large intestine.
Okay,
That's-
sorry, yeah. Got
So
my
you have the
terms
small
wrong.
intestine and you have the large
Large
intestine, which
intestine.
is the colon, yeah.
Okay.
We look in the colon, and then we can look in the very end of the small intestine with the
Okay.
with the colonoscope.
Okay,
Yeah.
very good. So we talked about that every 10 years, and
If you have an average risk and you don't have any other health issues,
Okay.
that would say you needed to have it more frequently. So
Okay.
if you have polyps or something like that, if you have a family history,
Then you
if
don't.
you have inflammatory bowel disease, which is ulcerative colitis or Crohn's disease, then it wouldn't be every 10 years for those people.
Okay.
Their intervals for colonoscopy would be different.
okay.
Yeah.
We'll talk a little bit more about that. We're going to take a quick break.
Okay.
And then we'll come back and we can focus on that a little bit more. So stay tuned. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Dr. Carol Lee Collins. Thanks again for being on the
Thank
show.
you again.
And we're talking about tummy issues because you're a gastroenterologist. So that's stomach, liver, pancreas, That's
colon.
basically from in to out
Mhm.
and everything in between.
Mhm.
So we had just started talking about how normal, if you have a regular and don't have any family history or any other problems, then you just need to go every 10 years for that infamous colonoscopy. But if you have some issues, polyps, things like that that come up, how often? Is it yearly, every couple of years?
Well, for polyps, depending on the type of polyps, that determines
How often.
how often. The type and the size
Okay.
are the determining factors.
And through a colonoscopy is usually how you can identify like colon cancer,
Yes.
right? And that's usually something, if you catch it early.
If you catch it early, certainly it's better than if you don't catch it early. Yes.
Right.
Yes.
Are there any symptoms that someone would be aware of to watch for?
For colon cancer?
Uh-huh.
Yeah, change in bowel habits.
Okay.
Certainly abdominal pain, blood in the stool, that kind of thing.
Okay, those are all like danger signs for
Those are things
other
that
things,
you
and
should.
not just cancer,
Right.
obviously, but
But yeah, you can have those things and not have colon cancer. But certainly, if you have those symptoms, you should talk to your provider.
get to the doctor.
Yeah.
Those are not good things.
Yeah.
Okay. So liver, what kind of things do you see with the liver? And
Well, we see hepatitis, like hepatitis C, B. Those are viral hepatitis that can cause chronic liver disease and lead to cirrhosis of the liver. Hepatitis A is also a viral hepatitis, but it doesn't lead to chronic liver disease.
oh, it doesn't. Now, what is the difference between A, B, and C, and how?
Well, the differences are just the type of virus that they are,
Okay.
and the way you get them.
Right.
Hepatitis A is usually gotten from eating something
Okay.
that was touched by someone who was infected. Hepatitis B is either intravenous use or blood transfusions. The same thing with hepatitis C, but they're different types of viruses.
Okay.
But in this country, hepatitis C is a big issue.
That's the one that you see more commonly in.
Right, in this country.
Okay.
Yeah.
Okay.
Yeah.
And is there anything you can do for those?
There is treatment for those.
Okay.
I don't treat them here.
Okay.
The infectious disease doctor
Oh,
does.
Dr. J. Kahn?
Right.
Okay.
But we certainly diagnose them.
Okay.
And if people have developed cirrhosis, which is something that happens if the hepatitis is not treated, we see a lot of those patients.
Okay. And
Yeah.
again, is that something treatable? I mean, I've heard cirrhosis of the liver. You hear that can be pretty serious.
It is very serious. Yeah, there's some things that you can do to prolong the time frame from the time they're diagnosed to the time they need a liver transplant.
Okay.
So it's just kind of health maintenance.
Okay.
You know, we kind of tackle the issues as they come about.
So cirrhosis usually, though, is serious enough that they have to end up with a transplant.
Well,
That's
some
it.
people do. People can live with cirrhosis for a long time.
Oh,
though.
okay.
If they
They change their lifestyle.
right,
Kind of
if
thing.
they stop drinking, that was the reason. There are some people with early cirrhosis who can get treated for hepatitis, those kind
Okay.
of things. So that can prolong their life. Then there are other liver diseases which are not as common that we see as well that can attack the liver.
Like what?
Something called autoimmune hepatitis.
Oh, okay.
Or primary biliary cirrhosis. Those are other diseases that we see that can cause chronic liver disease.
Wow. Okay. And then pancreas. That's the other thing you mentioned.
Right. That's pancreas is kind of the gland in your body that helps you digest things. It produces hormones that help you to digest food and to regulate insulin and that kind of thing.
Oh, okay.
Blood sugars and that kind of thing. So
that's a pretty important little piece.
oh yeah, it's very important. You know, it can be affected by a lot of different things, medications, alcohol is a primary thing. In this country where people can get what we call pancreatitis or
Right.
inflammation of the pancreas
Okay.
from alcohol use.
And again, the best cure is to
Well,
quit drinking.
Stop drinking if you have there's acute pancreatitis and then there's chronic pancreatitis.
Okay.
And so chronic pancreatitis usually is from alcohol use. And yeah, if once the pancreas has been damaged, then stopping whatever insulted the pancreas, like alcohol, is the first thing that we tell people to do.
And then what other treatment is there besides quitting the drinking?
Well, it depends on what else is going on with it. I mean, you can develop stones and things like that in the pancreas
Oh,
ducts.
really? Like gallbladder stones?
Well,
Or-
but they're pancreas duct
Uh-huh,
stones. Yeah.
okay.
And so people can get treated for those kind of things.
Okay. And now I've talked to someone one time, they were mentioning that they had pancreatitis, and they had drank for a number of years, and they thought, oh, so I can just have one. And they had just one, and it just like brought it right
Yeah.
back.
Yeah.
So pretty much once you damage the pancreas, it's not
It doesn't.
one-
It's not reversible.
Oh, okay.
Yeah.
So you're pretty much, it's better not go there to begin with.
Right. Yeah. Try to prevent it from happening.
Okay.
But pancreatic cancer is also something that can occur in the pancreas.
And that I was going to ask about that. Now,
Mm-hmm.
what are the symptoms of pancreatic cancer? How would you know that you have that?
Well, unfortunately, the symptoms come late in the disease.
Well,
By the time people have symptoms, like they can become jaundice or they can have pain,
Mm-hmm.
weight loss. Some people just have a decrease in their appetite. They have funny taste in their mouth. That
and
kind
that's
of
from
thing.
the pancreas? Or
That's from the pancreatic cancer.
Okay.
By the time they have symptoms, though, it's kind of like almost too late.
Wow. So this.
Yeah.
So how do you find it early?
Well, there's no recommendation at this time to screen for pancreatic cancer unless there's a family history.
Oh.
If there's a family history of pancreatic cancer, because there's some hereditary forms of it, then you would do something called an endoscopic ultrasound, which is not something that we have available here, but we
Okay.
can send you to Phoenix for that.
Okay.
Yeah.
So when you have that, so that goes down through the mouth,
Mm-hmm.
and that goes. So they can see the pancreas through that.
Oh, yeah.
I didn't realize that.
Yeah, it's a different kind of scope
Uh huh.
that has an ultrasound probe on it. And we
Okay.
use it a lot for diagnosing like pancreatic cysts or masses.
Okay.
You can see it's like a three-dimensional view of the digestive tract through all the layers of the digestive tract.
Wow, it's pretty amazing.
Yeah,
Our
it's-
bodies are kind of cool too, though. How
Yeah.
they have all those different pieces. It's got to be fascinating.
So, yeah, so
And how it
it's
works
something
together.
that we use a lot in GI these days.
Very good.
Yeah.
Well, I really appreciate you taking time because I know how busy you are.
Sure.
To be on this show and to get a chance for our community to get to know you better. Again, you said you're in Suite
221.
221
Yeah.
Medical Professional Center.
Yes.
And if they wanted to call for more information, what's the number?
681-8715.
Okay, very
Yeah.
good. So 8715. And
Yes.
you're on our website too.
Yes.
They go to
Mhm.
azkrmc.com under Find a Physician, and there you are, Lee Collins. So,
Right, yes.
very good.
Yes.
Well, thank you again.
Thank you for
And-
having me.
And thanks for coming to Kingman. We're glad
Okay.
to have you here.
Thank
okay.
you.
So join us again next week. I'll have another great guest on the program. Take care, and we'll talk to you then.